So good morning, everybody. I'm Sobha Sivaprasad from Moorfields Eye Hospital and King's College Hospital, London. My topic today is macular pigments in diabetes and glaucoma. And before I start, I need to tell you that there is very, very little research done on macular pigments in diabetes and glaucoma. They're very novel. There are less than 5 papers in literature about it. And secondly, I myself is a novice in macular pigment research. Harvard Foundation has just funded us a study on the role of MacuVision on, MacuShield on diseased macula. We have recruited 50 patients. Roxanne in the audience has done all the job on it, and our results will only come out by the end of the year. So this talk may be a little premature, and so most of the slides will be hypothetical rather than results. So I'll go through macular pigments. I think most of it is already covered by John, and then a few slides on glaucoma, then diabetes, and how we design studies in these topics. So as John has reiterated, there are 3 types of macular pigments. That's lutein, zeaxanthin, and mesozeaxanthin. And you'll see from John's lecture earlier that dietary lutein, if you take the ratio of zeaxanthin and lutein, in the diet, the lutein is much higher. And as it goes down to the serum level, the ratio increases between, decreases between lutein and zeaxanthin. And in the macula, you see that zeaxanthin is actually more than lutein. So that's how the ratio plays itself when it finally comes to the macula. Macular pigment profile in the retina. Here again, the macular pigments, as John reiterated, it is in the center of the macula, and lutein is the dominant pigment in the peripheral macula, zeaxanthin in the mid-periphery, and mesozeaxanthin in the center, or the epicenter of the macula. And that's probably why we get this visual performance improvement with supplements containing mesozeaxanthin. Properties of macular pigment, again, John has gone at length describing its central location, its effect as a blue light filter. And for these conditions of glaucoma and diabetes, the 2 major properties that macular pigments have that may be useful for these conditions are that its anti-inflammatory properties and antioxidant activities. So why did God put macular pigments in the central retina? That's the main thing that is important for the 2 conditions we are going to describe today. So the central retina is the area of highest metabolic activity of all parts of the retina, and therefore it consumes the most amount of oxygen, and that's why it's very heavily infiltrated by reactive oxygen species when exposed to light or other external stressors. It's also very rich in polyunsaturated fatty acid, another soil for the reactive oxygen species. So together with all these metabolites coming out of the retina and the effect of blue light, of course, that will be the soil for oxidative stress and inflammation. So this slide, John has already shown, it's from, it shows the effect of macular pigment on the retina and the effect causing reactive oxygen species to escape. For both glaucoma and diabetes, unfortunately, although the exact pathogenesis is not known, what we know is it's got an inflammation and reactive and oxidative stress as 2 of the main mechanisms of pathogenesis. So that's why macular pigments are becoming an important field in these diseases. Again, the location of macular pigments within the retina, it's usually found in the layer in the fiber of Henle at the fovea, but if you look at literature, it suggests that it can be found in any layers in the retina. It's quite confusing about where exactly it is located. It is important in case of diabetes and glaucoma because these structural alterations in the different layers of the retina differ, and therefore it shows us that it is important to isolate which layer of the retina is affected in these conditions to understand the effect of macular pigments. So firstly, glaucoma. As we all know or have been taught over the years, glaucoma is a disease of the peripheral retina. We know that the triad of diagnosis of glaucoma is pressure, intraocular pressure, optic disc changes and visual fields. I mean, that's been taught and taught again. Then why are we bothered about macular pigments in the center of the macula? I mean, it doesn't seem to make sense. I mean, before I was given this topic, I really thought I was given the wrong topic of macular pigments in glaucoma. I've never heard of macular pigments affecting patients with glaucoma. There was one paper, and it showed us that macular pigments, I mean, most commonly measured using macular pigment optical density, and the normative data suggests that MPOD averages to about 0.35. And in glaucoma, cases versus control, the macular pigment optical density was 34% lower in glaucoma than controls. So it tells us something. So definitely there is a role of macular pigments in glaucoma. Whether it's a cause or an effect, we do not know. And comparatively, in AMD, the difference was 53%. So it's significantly affecting glaucoma for some reason. We still do not know why. And this paper by Egress et al. Suggests that actually macular pigment decreases, and it does not correlate with the grade of the glaucoma or the severity of the glaucoma. So you can have a really high large cup disc ratio, but the macular pigments will be just as deficient as a patient with low cup disc ratio. So again, it's very confusing as to why it doesn't correlate with macular pigments. So back to glaucoma and central retina, if the macular pigments have to be affected, then we have to go back and look at the literature why it should be affected in glaucoma. And if you look at that, the papers are just coming out this year or early part of last year, where there are effects of glaucoma on the macula. Right? The macular ganglion cells close to the fovea are affected very early on in glaucoma, something we have never tried to explore. And it may be that that is what we are seeing as a biomarker as macular pigments being decreased. Okay. So central visual function changes are affected in early part of glaucoma. So even before visual fields are affected, as John said, before visual acuity is affected, you have poor color vision, you have problems with contrast sensitivity, you have electrophysiological changes in the center of the macula, suggesting that there are macular changes in glaucoma. Something we never cared for until the macular pigment research came up, and it shows that there's decreased macular pigments in glaucoma. Whether it's a sign of, whether that is the cause of the visual function, we do not know. But definitely it seems to now, at least we can hypothesize that there is something to do with a depletion of macular pigments and the poor visual performance. I mean, John has stressed several times today that visual acuity is not the best test for us to qualify visual performance. So you have contrast sensitivity, depth perception, color discrimination, and movement recognition. All these form the components of visual performance. And you can see that although we have very, very preliminary data on macular shield in diseased macula, what we see is the contrast sensitivity seems to be picking up much earlier than changes in visual acuity, because most patients are 6/6 Snellen when they are recruited into trials. So we have to use indicators that can pick up the effect of these sort of supplements on the visual performance. So again, these are postulations as to why macular pigments are reduced in glaucoma. So first and foremost, I've stressed again and again, oxidative stress is one of the pathomechanisms for glaucoma. And it might be that the oxidative stress causes the cytokine productions to increase. We produce a pro-inflammatory state, which then causes the ganglion cells to be destroyed. When the ganglion cells come down, then the oxidative stress has causes a depletion of the macular pigments associated with it. So that's one theory. It's as if the oxidative stress is causing a depletion. So it's an effect of glaucoma. Another postulation that's come up is that glaucoma is a microvascular disease, and therefore a depletion of macular pigments is due to a depletion of the circulation to the eye. So we know that in glaucoma, the ocular blood flow reduces, and therefore one reason of why macular pigments are decreased in glaucoma is that the circulation, microcirculation is affected in glaucoma. Third theory, it might be a macrocirculation, that is that what we consume in the diet may not go up to the eyes because of effects on atherosclerosis or circulatory disorders in the central retinal or posterior ciliary arteries. Again, all these are postulations. They are causative mechanisms that have been thought through about why we have a depleted macular pigments in patients with glaucoma. As you can see, the paper is extremely recent publication, and there's nothing else in literature as to why macular pigments decrease in glaucoma. So now we move on to diabetes. Again, there are two papers on macular pigments in diabetic retinopathy, really new area, but we'll just go through what we know about diabetes. So, I mean, being optometrist, I don't need to describe diabetic retinopathy to you, but as all of you very clearly understand, we do diabetic retinopathy screening every year on all our patients with diabetes. In the UK, the government sends £65 million trying to look up for microvascular changes in the retina. So we look for any sight-threatening retinopathy and refer the patients back into hospital for timely treatment. So this is a patient with severe retinopathy. Again, these are the type of patients we look out for when we do screening for diabetic retinopathy and refer the patients into hospital. But the question I want to stress is, I think we have already missed the boat by trying to look for these sort of microvascular changes in people with diabetes, because we are very much in favor of our old teaching of looking at visual acuity and then color photographs, dilating the patient, then do fluorescent angiogram and going down the way of laser or anti-VEGF therapy. But if you look at literature, there's quite a lot of data which suggests that this is quite late on in the disease, and we have to be thinking ahead of the game and trying to find out new methods of detection of a diseased retina even before the patient develops all these complications that cause visual loss. So from our early teaching, we know that when a patient has decreased visual acuity, we look for macular edema or macular ischemia or epiretinal membrane, cataracts, vitreous hemorrhage, and the like. That is what we have been taught. And we know that with all these microvascular changes, how does the vision or the nerves get affected? It's by compression. Okay, these microvascular changes causes swelling or hemorrhage, and it presses on the neurons, and therefore we get a compromise on our visual performance. That has been taught and taught and taught, and we still follow that. But the issue is, we do get visual abnormalities or abnormalities in visual performance very, very early on, before even any microvascular changes are visible clinically. So then the change in understanding of diabetic retinopathy is that actually diabetic retinopathy may be a primary neuronal dysfunction. And the evidence for it is OCT. As we know, for 5 years we have been doing OCTs on most of these patients. And we see thinning of the total retina in type 1 diabetes in patients with minimal retinopathy compared to normal controls. That means there is selective thinning of the inner retina before the onset of microvascular changes, at least clinical evidence of microvascular changes. Another example, the intermediate and low spatial frequencies of contrast sensitivities is reduced in diabetes compared to age-matched normal. So in a recent study by, in a study by Della et al., they said 37% of patients with no diabetic retinopathy compared to 60% with diabetic retinopathy showed a reduced contrast sensitivity in type 1 diabetes. And that effect was also shown in another paper in people with type 2 diabetes. So it tells us that contrast sensitivity is affected before the onset of diabetic retinopathy, and it also increases with severity of diabetic retinopathy. Right? So that means visual function is affected before the onset of microvascular changes. Again, we have reports of color vision being affected in patients with no diabetic retinopathy, and again it correlates with severity of diabetic retinopathy. And it also correlates with electrophysiological measures, suggesting that there is a neuronal dysfunction of the retina before the onset of microvascular changes. perimetry visual field test, cone abnormalities far before the onset of diabetic retinopathy. So why are we seeing all this? I mean, what is it telling us? It's telling us that when we screen for patients, we're chasing after microaneurysms for screening, we have already missed the boat. We have to find out what happens before the onset of microvascular changes. You'll ask, why should we find that we don't have anything to offer these patients? Then what's the point of finding out that they have a poor color vision or poor contrast sensitivity before the onset of microvascular changes? Well, we have just seen from glaucoma that they can be supplemented if the macular pigments are also reduced. This is yet another example of multifocal ERG in diabetic retinopathy. Multifocal ERG shows macular function test in diabetics. And you will see that compared to a non-diabetic here, patients with no diabetic retinopathy has already got a lengthened implicit time, and that goes on with severity of diabetic retinopathy. So I've shown you enough of evidence that there is neuronal dysfunction in diabetic retinopathy. So then the question is, well, we have always learned of microvascular changes, then how are the neurons affected? Yes, very easy to describe, it's all due to compression. But if you look at the intricate structure of the retina, it's very unlikely just that the microvascular changes are causing secondary effects of the retina. It's more likely that they are all affected, but at different time points, or they may not run in parallel. And with all the functional tests available, we now know that visual function actually, or neuronal function actually precedes, the abnormalities precedes the microvascular disease. So I'll skip that. So now we know that a patient with diabetes with normal retina on fundus examination may present with decreased night vision, decreased color vision, decreased contrast sensitivity, and electrophysiological responses suggestive of macular dysfunction. So what does this lead us to? The reasons why. The explanations that's given is it's again due to oxidative stress or excitatory signals from the nerve, the abnormal neuronal dysfunction, or direct metabolic factors due to hyperglycemia, or all these causing increased cytokines or increased inflammatory markers. These are examples of how complicated oxidative stress can be in patients with diabetes. And based on all that, what we now have is one paper on diabetic retinopathy, effect of macular pigments in people with diabetes. So this paper had 43 patients in the study, divided into 3 groups, 14 controls, 17 diabetics with no retinopathy, and 12 patients with diabetic retinopathy. And you find that the macular pigment density was depleted in patients with diabetes. And they also correlated it to the lipid profile, to the HbA1c profile, and through other variables to find out what exactly this meant in people with diabetes. So they found that type 2 patients with or without retinopathy, see that it's with or without retinopathy, had reduced MPOD compared to non-diabetic patients. They haven't correlated this with visual function, so that's what we are doing in our study. We were not allowed to do it just on diabetics, so we have comprised it as, we have compiled the study as diseased macula. We're looking at different visual function tests and the relation to macular pigment density, and whether changes in macular pigment density will then alter the visual function test. The results will be out only by the end of the year. And when we look at HbA1c, that gives us a clue as to why the macular pigments may be affected in diabetic retinopathy. You see that macular pigments correlate with HbA1c levels. So the higher the HbA1c level, the lower the macular pigments. So it might be related to the same BMI, lipid content, etc., but it gives us a clue as to why all this falls in place. Sources of macular pigments, I think John has given enough of literature on this today. All what I was trying to say is that we do not get this completely from our diet. So we will need to take macular supplements as you grow older, because we are not going to get them very early on in the diet. So in a patient with diabetes, at present we cannot prescribe them a supplement, but I think I wouldn't be surprised that within years, we will be saying, if you are a diabetic, just like what we tell our macular degeneration patients, I think it would be good for you to be on a macular supplement, especially if you are to improve and cause the supervision in these patients. You should be taking something with mesozeaxanthin as well for the central vision. Spatial profile of macular pigments. I know we are going into details on measurement techniques in macular pigments, but there's a word of caution when you do studies on these, in that if you're doing measurements with one instrument, make sure that that's carried on throughout to the end of the studies. The measurements are different between machines and how they do them. So it's a word of caution as well when you compare studies. If you do a meta-analysis on macular pigment optical density papers, make sure you get it by measurement of the measurement technique as well, and not just looking at depletion measurement errors. And this is my last slide, because when we started our study, we had the problem, a teething problem with our MPOD measurements. And that's why I thought it's very important to share this with anyone who is trying to do this. These are very easy to do, but in the meanwhile, it's also very easy to make mistakes on them. So it would be useful for everyone who is trying to purchase these machines to find out if your patients have decreased macular pigment, is to try and calibrate them well enough so that your measurements are accurate before you start measuring patients and declaring that they have depleted macular pigments. So in conclusion, it's a relatively short talk compared to John, and that's just because I do not have any literature on this topic. All I can say at present is macular pigments are depleted in glaucoma and diabetes. In glaucoma, there is no correlation with the severity, but in diabetes, I think we will get more data very shortly. In our study, we are not focusing on glaucoma. The prevention trial using macular pigment supplements will help us determine the exact role of macular pigments in these diseases. It's really new, but I think it will be an exciting topic for whoever want to do research in this area, because it's going to tell us more about these diseases than we ever knew. Thank you. Any questions?
Hi, Sobha. Thanks for an excellent talk. Is there any possibility that the dietary restrictions of diabetes could influence the macular pigment in diabetics?
I couldn't say, because type 1 patients who are already quite lean and have low BMI, they still have depletion of macular pigment. So I'm not quite sure whether restriction is as bad as taking too much. I really don't know. But I think adipose tissue will count because they are a competitor for lutein. So yeah, in that respect, yes. Thank God I don't have questions, because I wouldn't be able to answer. I really don't know much about it.